Where's that big cup of coffee?
I forgot it this morning.
No, no. You'll pay for that probably.
Pardon?
You'll pay for that probably.
Yeah, probably.
11:30, you'll be dragging all around campus. Yeah, I didn't think I'd see the day when Elena beats you.
Yeah, I came in as well. That's right. Dr. B, I have to leave a little early, if that's okay.
Just you or the whole team?
Yeah, yes,
Okay.
Oh, I'm gonna, it's towing class. I'm gonna text her instead of bring the t-shirt, but I can't get in. Oh, thank you. Yeah. Like 11:30. Yeah. Because like I would have had that extra like 3-hour period if we didn't play to look at the mechanism tomorrow.
And it's time to begin. Good morning. So the quiz is available online. Please make sure you get that done before Monday is the end of the day. End of the day meaning midnight. And I know some of you like to put things off to the last minute. You might want to give yourself some time so that you're safe. If things come up, you can't somehow get to the test because of circumstances beyond your control, well, do let me know. I know that happens. So just do what you can. Okay. We are talking about the treatment of angina pectoris. We got into a discussion of nitrates. We'll finish that and then move on to some of the other treatments as well. Let's pray. Father, thank you for this nice day. Thank you for a nice week. Weather-wise, we pray for a weekend that looks just a little bit colder, but also equally nice. We pray, Lord, as the weather gets better, you keep our minds from wandering. Oh, I want to be outside. I don't want to be studying. Lord, help us to stay strong all the way to the end. In Jesus' name, amen. Okay. Nitrates. So nitrates are potent vasodilators. They dilate both arteries and veins. Now, to understand why, if you take a look at page 51 of your notes, you will see the little biochemical pathway by which smooth muscles either contract or relax. So if we look at this, we can see that the regulation works around myosin light chain. So myosin consists of a heavy chain and a light chain. The light chain is more of a regulatory chain. If that light chain is phosphorylated, that facilitates the association of myosin with actin, and you get contraction. If the smooth muscle contracts, the vessel will undergo constriction. If, however, myosin light chain is not phosphorylated, then myosin will not tend to associate with actin. You will tend to get relaxation of that smooth vascular muscle, and the vessel will dilate. So, cyclic GMP promotes dephosphorylation of myosin light chain. Dephosphorylation of myosin light chain. Therefore, cyclic GMP promotes relaxation of smooth muscles and promotes vasodilation. Nitric oxide activates the enzyme that makes cyclic GMP. That's why nitrates promote vasodilation. Now you'll notice this other little molecule there, sildenafil. Does anyone know the trade name of sildenafil? I'll tell you, it's Viagra. Viagra. That's how Viagra and its other drugs like it in that class work. They promote vasodilation by promoting the half-life of cyclic GMP. They inhibit the enzyme that breaks down cyclic GMP. And there are other drugs in this group, and they're used to treat a condition called pulmonary arterial hypertension. So they're not just, excuse the expression, whoopee drugs. They're not just drugs for erectile dysfunction, they're also used for things like pulmonary arterial hypertension. So that's how your nitrates work. And looking also at this table, well, this diagram, you'll note that cyclic GMP also is going to play, cyclic AMP is also going to play a role as well. And it is going to also promote constriction of the vessels as well. So if you promote the breakdown of cyclic AMP, you will tend to promote vasodilation as well. And we'll look at some drugs that actually work that way too. And then calcium plays a role as well. So if you prevent calcium from coming in to the cell, the smooth muscle cell, that can also promote vasodilation too. So that shows you the role for calcium channel blockers, for organic nitrates, and so on and so forth. Okay, so the nitrates are vasodilators. They dilate coronary arteries, but they're also going to reduce afterload and preload because they're dilating those vessels. The vessels that lead into the heart, the vessels that the heart have to pump into. They're decreasing both preload, afterload. That decreases the oxygen demand of the myocardium, and it increases blood flow to the myocardium. So you're really treating allergy season, you can tell. Or they're treating angina both ways, decreasing cardiac muscle oxygen demand and increasing cardiac muscle oxygen delivery. All right, so nitroglycerin will be largely short-term, but there are preps that can be long-term. And then isosorbide mononitrate, that's usually only available as a pill, orally. You can give nitroglycerin in the ER intravenously. There is an intravenous form of it. And you usually give that if a patient comes in and they have some left ventricular dysfunction. Incidentally, you never give nitroglycerin if someone has right heart dysfunction. That makes the right heart dysfunction worse. So you relieve cardiac pain. That's one of the biggies with nitrates. They're symptomatic and they're very good at that. You can also use them prophylactically. And sublingual nitroglycerin is definitely the one that's used the most. There are forms that can be used more long-term. These will give you incidence of less frequent dosing. We talked about the side effects, headache, dizziness, hypotension, and then we talked about tachyphylaxis. Remember, your nitrates promote the synthesis of cyclic GMP. If you run out of GTP, nitrates don't work anymore. That's tachyphylaxis. Tachyphylaxis. That's why nitrates, you never want to overuse them. And if you have a client, a patient on nitrates, that's one of the big education parts of it, is you have to make sure they don't overuse nitrates. They have to spend time off the nitrates as well as having time on the nitrates. Don't use nitrates with phosphodiesterase inhibitors. That would be drugs like Viagra, drugs like tadalafil, Cialis, or vardenafil. Don't tell me. Levitra, any of those drugs that you see the really tasteless commercials on TV for those drugs. And yes, they are tasteless. Commercials like that, you can make them funny, I think, but no, they're just tasteless. If you combine those two drugs together, you'll get a really dangerous drop in blood pressure. So don't combine those drugs ever, ever. Okay, so the tolerance, issue. There are effects on systemic blood pressure, that is, it tends to drop systemic blood pressure. That drop in systemic blood pressure will tend to be accompanied by a compensatory reflex increase in the heart rate. The increase for some people can be substantial. In others, it's just a slight increase, so it varies from person to person. And why the heart rate will decrease with long-term therapy, that's not terribly well understood. Okay, so the sublingual is definitely the one that's the most commonly used. So nitrostat is your kind of go-to tablet, sublingual tablet. So this is a quick melt technology, goes under the tongue, and it dissolves in a couple minutes. Usually starts working 3 to 5 minutes. Go Nitro comes in a packet, and it's a powder. You take the powder and you stick it under your tongue, but you can also cheek it. And if you have people who like to chew tobacco, they're used to chewing tobacco, which incidentally, I really think is a disgusting habit, but there you are. This product is really works well in those people because they know how to cheek it and so on and so forth. Your buccal mucosa is full of blood vessels. And those buccal blood vessels take up the Go Nitro product very quickly. So the dry powder goes over very well. It should not be swallowed, by the way. There are also sprays. So there's nitro mist, nitro lingual. Nitrolingual, you spray under or on your tongue. This has replaced the oral tablets of nitroglycerin. Oral tablets of nitroglycerin are no longer available in this country. Then you get the patch. Nitroderm was discontinued. It's just available now as a generic. And the patch, if you wear a nitro patch, make sure you take it off for MRIs because there's metal in the patch. Also, if you take off the patch, seal it, and then don't just throw it in the trash if you have kids around, because kids, the patches are gooey and the kids think they're interesting. And kids have actually died going into the trash and saying, oh, look, this is cool. You get the nitrates all over them and the blood pressure drops precipitously and kids have died from that. So patches, you should take them, put them together and flush them down the toilet. And that's an education piece for patients. Don't throw them in the trash. Kids will, especially if you have little kids around, if you're a grandparent, you have grandkids around, because that's an issue. Also, patches, you have to spend at least 10 to 11 hours with the patch off if you wear the patch. The patch is very good for prophylactic treatment. Very good for prophylactic treatment. And you remove the patch at night. Then there are ointments as well. Some of these ointments are rectal, Rictiv, that's what Rictiv is for. And that way you don't have to worry about the ointment being anywhere else that stains your clothes or something like that. So the transdermal patches, they're 5 mg. They're made for 5 mg for every 24 hours. You can also use sublingual nitro with this as needed. This is not good for acute attacks. Sublingual nitro is good for that. This is good for prophylaxis. So 12, 14 hours off for every 10 to 12 hours on. Sorry, 12 out, 12 to 14 hours on, then you have to be off every 12 to 10 to 12 hours. That way you recover, you make your GTP, you're not going to have tolerance. That's pretty important. Ointments. Make sure the ointment is applied to a hairless area. And if you're really hairy, you might want to shave something. These come with an applicator. Don't get it on your fingers. The vehicle, the ointment's on, will take it right through your fingers. You'll get too much of it and you'll pass out. So use the applicator. You massage the ointment onto a small area, 4 to 5 inches. Stay away from scars. Stay away from your navel. At least 2 inches from your navel, at least 1 inch from a scar. Scars don't allow nearly as good absorption, even though scars are hairless. So you gotta stay away from scars. Before you apply the next dose, make sure you clean the area. The ointments are stable at room temperature, but if you expose them to high temperatures, that will tend to damage them. If the ointment starts to separate, it gets liquidy at the bottom, it's no good. It's no good. You need to get other ointment. That happens if it's been heated or if it's just old. Sublingual nitroglycerin has to be stored away from extremes of temperature. So putting it in a glove box during a Michigan summer, not a good idea. You want to keep it also out in the sun. The drug, you must be aware, it may cause dizziness when you pop your first pill of the day. And make sure that you're aware of the shelf life. These drugs have a shelf life. You have to be aware of that because it can go bad. Nitrostat comes in a tinted bottle. That's to protect it from the sun. And all patients on sublingual nitroglycerin should be informed that this preparation is light sensitive. So it's best to store it in the dark. No cotton. No cotton. The cellulose in the cotton will react with the nitroglycerin and degrade it. So if you get the bottle, if the bottle has cotton in it, open it, take the cotton out, and store it that way. Because the prep may have cotton in it just because that's standard practice. Pull the cotton out, don't use cotton. Don't mix pills. You have pills from different prescriptions, they have different potencies. Then you don't know how much you're getting, don't mix pills. Make sure it's not heated. That's also really important. So you can use it every 5 minutes for 3 times. If you don't get relief after that 3rd pill, something's wrong. You need to go to the emergency room. Also, another tip about nitroglycerin, don't lie down after you've taken nitroglycerin. If you lie down, you will increase rather than decrease preload. And you're defeating the purpose, your chest pain might get worse. So it's best at first to take it sitting. If you do stand up, be really careful because you'll probably get syncope if you stand up too fast. Oh, another tip for patients, and especially those of you who are going to be OTs. If a patient's on nitro, everyone, they should have some sort of medical alert that tells people they're on nitro. Also, if you call 911, make sure to unlock your door. Because it's not uncommon for EMTs to get to two houses. You're ringing somebody, nobody answers, you can't get in. What do they have to do? Break a window. So if you call 911, unlock your door. That's important. Key, we might say, well, yeah, duh, but in the midst of an emergency, you forget stuff. So call 911, unlock your door, or unlock your door, then call 911. And this just shows you the efficacy of the different preps of organic nitrates. So you can see, let's see here. Sublingual acts quickly, doesn't last very long, but it's really good for acute attacks. You overdo it, you have chest pain, you pop a sublingual nitroglycerin, the pain goes away. Very, very good for that. That's what it's for. And if patients have angina, they shouldn't just sit down and tough it out. They should use their nitroglycerin. Because nitroglycerin will not just relieve the symptoms, because it decreases the work your heart is doing, it's actually good for your heart too. So don't tell them, don't be an old soldier, stop the nitro, use the nitro. Emily, was that a question or you're stretching? Okay, that's fine. Stretching's good. Okay. Okay, there is a sublingual isosorbide dinitrate. That's not used that much anymore. That takes longer, lasts longer, and the efficacy of this drug is erratic from patient to patient. That's why it's really not used much anymore. Still available as far as I can tell, but you won't find many clinicians who prescribe it. The oral isosorbide mononitrate is used. That takes longer for onset, but it lasts much longer. So this is good for prophylaxis. Then there's oral nitroglycerin in the form of sprays, and then you have your ointments and your patches. And the patches are more expensive. Now that they're generic, they're not that expensive. They're about $15 a patch, which they're covered by Medicaid, Medicare, especially now that they're generic. Ointments are cheap, very cheap. And the application technique here is really important. Sprays are good. The beauty of sprays is they're easy. Very easy to apply. The newer sprays are expensive. The ones that are in generic, pretty cheap. So sprays are being used more and more. Now, in the algorithm I sent you, treatment algorithm for angina, you can see that for your class 2 angina, that the combination of a beta blocker plus nitrates or beta blocker plus a calcium channel blocker is essentially your treatment of choice, again, plus a daily aspirin. What dose of aspirin? Anybody remember the aspirin dose? If you're in healthcare, that one should roll off your tongue. 81 to 375. 81 mgs to 375 mgs. 81 mgs is a baby aspirin, or they're called children's aspirin. 375 is an adult aspirin. So either baby aspirin or an adult aspirin, take your pick. Now, if you use a calcium channel blocker. For angina, it's best to use the cardiospecific calcium channel blockers. So that would be verapamil or diltiazem. You do not mix verapamil and diltiazem with beta blockers. If you do, you're at a great risk for a heart block. So don't mix those two drugs. So it's either going to be either or. Now, the non-DHPs, diltiazem, verapamil, they're going to work in the heart muscle. They will slow the conduction of the signal to beat in the heart. That will slow down the work the heart does. That will decrease oxygen demand of the myocardium. Now, can you combine beta blockers with a DHP? Yes, you can, but you have to do that with some caution because you're going to lower the blood pressure even more. While that's a possibility, do be very careful if you do that, because you may get hypotension that may cause your patient to stroke out. All right, now the beta blocker has a proven role in treating angina chronically. So the beta blocker is preferred. If your patient can't tolerate beta blockers, and there's some who can't, their heart rate just gets too low, their fatigue is just too great for whatever reason, then you can go with a calcium channel blocker, and they can be successfully combined also with organic nitrates. And you can combine the calcium channel blocker, the DHP types, with the beta blocker if the monotherapy is not successful. Now, DHP, calcium channel blockers, are the drugs of choice for the Prinzmetal, the vasospastic angina. Do not use beta blockers for vasospastic angina. Beta blockers will make vasospastic angina worse. So DHPs are the drugs of choice for vasospastic angina. They work very well for that. They relax the smooth muscles around the coronary arteries. They dilate those coronary arteries and they prevent the vasospasm. They're quite good for that. But long-acting forms of the DHPs are preferable because the short-acting forms are associated with extensive reflex tachycardia. And if you induce tachycardia, that means your myocardium is consuming more oxygen. You're consuming more oxygen, then you're defeating that purpose. You're going to have more angina attacks. So the long-acting forms, sustained release forms, those are the ones you want to recommend. Don't use the short-acting forms. So your DHPs will tend to cause things like headache and flushing. You may get swelling on the feet and or ankles. Constipation is more a problem with verapamil. Not so much a problem with the DHPs, but it's definitely a problem with verapamil. So if your patient's on verapamil, they need to eat fiber and probably take Miralax or something like that, or some of the available commercial fibers, Benefiber, Citracil, things like that, because verapamil will slow down the transit time of the GI tract. Diltiazem will decrease it a little bit, but you don't usually get the really roaring constipation you get with verapamil. Don't use verapamil and diltiazem if you have an AV block. It'll make the AV block a lot worse. Some of the DHPs can cause reflex tachycardia. This one here, the long release amlodipine, is prone not to do that. Whereas nifedipine is kind of the worst offender in this group. And as I said, these are quite good for the vasospastic angina. Oh, yeah, one more thing. Verapamil is an inhibitor of two cytochrome P450s. It's an inhibitor of cytochrome P450 2D6. And it's an inhibitor of cytochrome P450 1A2. And it's a moderate inhibitor of cytochrome P450 3A4. So this drug has a lot of drug interactions. Make sure you check for drug-drug interactions with verapamil. Diltiazem is a 3A4 substrate. It inhibits 2D6 a little bit. So that inhibition doesn't seem to be very clinically significant. Now, if your patient has coronary artery disease, several different studies have shown that ACE inhibitors are a good drug to be on. They decrease morbidity and mortality. Of course, they are renal protective. They control blood pressure. They vasodilate without causing any sort of reflex tachycardia. But while the angina themselves may not be affected by the ACE inhibitors, all the studies that have been done, this HOPE study is actually a very large study of people who've had heart attacks and then people that had risk for coronary artery disease. Consistently, these drugs reduce morbidity, mortality. So that's a drug you might want to consider for such patients, especially if their blood pressure is kind of borderline. ACE inhibitors might be considered. And then you want to make sure that their LDL is under control. And again, statins, time and time again, even low-dose statins have been shown to reduce morbidity and mortality. The data here is not in dispute at all. Very clear. Now, there are some new kids on the block when it comes to treating angina. So these two agents are kind of out of the norm, but they're interesting drugs. There's not quite as much data on them, so they're not being used quite as much, but there might be a role for these drugs, at least in some patients. So this drug here, ranolazine, is a late sodium current inhibitor. A late sodium current inhibitor. What does late sodium current inhibition do? By blocking the late sodium current, which becomes very prominent during cardiomyocyte ischemia, the drug will inhibit the subsequent calcium overload that you tend to get within ischemic myocytes. That calcium overload causes the myocyte to absorb and consume more oxygen. So you prevent this calcium overload in ischemic myocardium. By doing that, you decrease myocardial oxygen consumption. And this is available in a ER tablet, 500 mg BID. Everyone know what BID means? BID means twice a day. Twice a day. BID twice a day, TID 3 times a day, QID 4 times a day, QD daily, so on and so forth. Nursing talk, sorry. So now you know BID means twice a day. TID 3 times a day, QID 4 times a day. The other drug is called ivabradine, and this inhibits the funny current. The funny current occurs in the pacemaker cells. So it inhibits the funny current. It decreases heart rate. You decrease heart rate. You decrease myocardial oxygen consumption. You decrease angina. And that, as you can see, is a drug that you don't take at very high dosage at all, but you take it twice daily. PO, do you know what that means? By mouth. PO means by mouth. So in their clinical trials, both drugs were pretty well tolerated. So ranolazine in patients who had side effects tended to cause things like dizziness, headache, some constipation, and a percentage of patients had nausea. There was some slight increase of the QT interval, but none of the clinical studies could show that that had any clinical significance. By and large, the drug was pretty well tolerated. Ivabradine also is pretty well tolerated, but in about 15% of the cases, there was this thing called luminous phenomena. That is, patients often had sensations of enhanced brightness in fully maintained visual fields. They called these phosphenes, P-H-O-S, P-H-E-N-E-S, phosphenes. So in your areas where you're looking, essentially, so if you're, say, in this room, you look at the lights would be a lot brighter than they would normally seem. Again, that didn't happen in everyone, but it happened in about 15% of the patients, and it's due to the fact that the potassium channels that they inhibit in the heart are also found in retinal photoreceptors. That was completely reversible too. So I'm sure it scared people out of their wits. So those are newer drugs. All right. So what is a healthcare worker or a prescriber or someone like that to do? So H and P refers to health and physical. What is the limitation of that person on their physical activity? Does the drug regimen that you've given them allow them to do the things that they normally like to do? How many attacks are they having per day? You want to decrease the number of attacks per day. If you have more than one episode a day, your condition is chronic. What sort of lifestyle modifications has your patient undergone? People with coronary artery disease need to change their diet. They may not like it, but they need to change their diet. They need to eat fewer saturated fats. They need to have less trans fats, if any. They need to have more fruits and vegetables. and they need to eat less red meat. Now, I'm not one of these people, oh, red meat is poison. No. I think red meat is fine, but I think red meat is fine in moderation. And if you have coronary artery disease, you should be eating less of it. You should be eating more white meat, like chicken breast and things like that, and what have you. So also, if you go to the butcher and you do eat red meat, look for cuts of meat that aren't as marbled. Look for cuts of meat that are leaner. You might have to pay more for them, but that will do that in the long run. That higher quality meat will be better for you. And then you want them to have treatments for acute attacks. You also want them to be able to have treatment that makes sure that they're able to do the things that they want to do. And then diagnostic testing. Are they stress tested? Is their EKG holding steadily? If it's worsening, then you need to consider things here. You want to make sure that their tests are showing that they're essentially holding steadily. And this table essentially is just meant to give you an idea of what's used for what. So your beta blockers, as you can see, are extremely useful. Let me just say a word about beta blockers after a heart attack. After a heart attack, in order to kind of kick the heart in the rumpus, your sympathetic nervous system starts really poking the heart. And so the heart gets extra heavy doses of norepinephrine. Research has shown that the heart, because it's being bathed in norepinephrine, that norepinephrine becomes toxic to the heart. So beta blockers after a heart attack are cardioprotective. And virtually now every cardiologist will say, after a heart attack, except under certain circumstances, you should go on a beta blocker. And again, it's those beta blockers that are shown to be useful in patients who've had a heart attack: carvedilol, bisoprolol, and extended release metoprolol. So that is kind of a must do. And then your nitrates, we talked about those, and then your calcium channel blockers, if your patient can't tolerate beta blockers. And again, be able to distinguish between when you use dihydropyridines and the non-dihydropyridines. Remember, the non-dihydropyridine calcium channel blockers are heart specific. The DHPs, the dihydropyridines, they're specific to vessels. Specific to vessels. They cause the vessels to dilate. All right, before I pack that up, are there any questions on angina, treatment of angina, anything like that? Yes, Allison. Right. So if the calcium channel blocker so if the drug ends in dipene, it is a DHP. So amlodipine, nifedipine, nimodipine. So dipene. So my stupid mnemonic is you have two pine trees and they're sitting close together, and these are like a channel. They're like a channel that lets calcium in, and they're going to block that channel between the two pine trees. So they're dipenes, two pine trees. That's how you remember dihydropyridines. They block the L-type calcium channel, but they're specific for blood vessels. Whereas verapamil and diltiazem are more specific to the heart. Verapamil is very specific to the heart. Diltiazem is mostly specific to the heart. So diltiazem will also cause some vessel dilation, whereas verapamil will cause very little vessel dilation. That help? Any more questions about angina pectoris? Treatment, management, pathophys, anything like that? Nope. All righty. And now for something completely different. Well, not that different. Let's talk about managing heart failure. Heart failure management has come a long way in just the last 10 years. It seems like nowadays, every year, I have to redo this lecture because there's new strategies, new drugs. Essentially, this is the best time ever to have heart failure because the discoveries in the last 10 years have greatly increased the prognosis for someone with congestive heart failure. Used to be the case if you had heart failure, it was basically keep it from getting worse, but your best strategy was to bend over, grab your ankles, and kiss your butt goodbye, because that was really about the best you could do. And I'm not kidding. I'm really not kidding. So now there are ways essentially not just to stabilize the heart, but actually to partially reverse it and get the heart into a place where the patient actually can now enjoy a relatively normal life. Are any of you familiar with the evangelist, Pastor Vodi Bakum? Vodi Bakum is he left the United States to be head of a seminary in Uganda, I think it is. And he's suffering now from heart failure. And he's experiencing these treatments, and his heart now is doing much better than it was before. He had a setback, but looked like he might have to have a heart transplant. But now he's doing much, much better. And simply because the strategies have gotten so much better for treating heart failure. So here are the 4 pillars of heart failure treatment. 4 pillars, they're right up there. First of all, you must inhibit the renin, angiotensin, aldosterone system. You must inhibit that system. In heart failure, that system gets hyperactivated, and that system drives deterioration of the heart. You must inhibit that system first and foremost. Vodi Bakum, by the way, has a new book coming out called Fault Lines about the critical race theory and its role in the church. A very good book. I recommend it to all of you. Secondly, beta blocker. Patients have to be on a beta blocker, and they have to be on a cardio-approved beta blocker, carvedilol, bisoprolol, or extended-release metoprolol. 3, people with heart failure retain fluid. Because they retain fluid, they must be on some sort of diuretic. 4, and this is new. This is a huge surprise. There are drugs for diabetics that are called SGLT2 inhibitors. This is the sodium glucose cotransporter 2 inhibitor that's in the proximal convoluted tubule of the nephron of the kidneys. These prevent glucose reuptake in the kidney. So they used to drop the blood sugar in people with type 2 diabetes. But it was shown in many studies that these patients with type 2 diabetes, that when they got on these drugs, all of a sudden their hearts improved. In fact, their hearts improved starkly. So cardiologist said, oh, I don't know, here's a Hail Mary. Let's try this on this heart failure patient and see if it improves their heart. And it did. So now these drugs are being used on non-diabetic patients who have heart failure. And the results keep speaking for themselves loudly. They protect the heart. So these SGLT2 inhibitors, these sodium glucose cotransport inhibitors that are normally used for diabetics are now being used in heart failure patients. And the data just keeps speaking for itself. So now it used to be a three-legged stool. Now it is 4 pillars of heart failure treatment. All right, any questions about those before we get into the actual drugs that you use to treat heart failure? Ram, you're asking Corinne about something. You can't find the PowerPoint. I'll make sure after class, I'll make sure it's on. Okay. Now, in order to understand some of the ins and outs of heart failure, we need to review a little bit about cardiomyocyte physiology. So remember that contraction requires calcium. And without calcium, basically the heart's not going anywhere. So calcium comes in via the L-type calcium channels. Remember, those are voltage gated calcium channel. But there's another way to get calcium into the cell. And it's by virtue of this sodium calcium exchanger. Sodium calcium exchanger. This will exchange sodium for calcium. So think about this with me. If there's more sodium out here, are you going to be able to get, if there's more calcium, sodium in here, you're going to be able to get more calcium into the cell? Sure you will, because you'll have the sodium go out and the calcium come in. So the sodium potassium ATPase pumps sodium out of the cell. What happens if you don't have the sodium potassium ATPase doing its job? You'll be able to pump more calcium into the cell, won't you? That will increase the force of contraction, because remember, the release of calcium from the SR, the sarcoplasmic reticulum, is stimulated by calcium in cardiac cells. And why is that cut off? That is very strange. I don't know why it's doing that, but it's cutting off my slides. There should be a piece down here that shows you the contractile elements of the cell. And they're, not working. So anyway, upshot, more calcium, stronger contractions. More calcium, stronger contractions. Now in congestive heart failure, the heart loses the ability to pump blood to the organs. Therefore, a heart that pumps more forcefully might be desirable. And there are drugs that will help you do exactly that. We'll get to them in just a second. First, let's talk a little bit about the pathophysiology of heart failure. So this is your ejection fraction. When the heart starts to fail, as the tissues and organs don't receive the blood they would normally receive, one of those organs is the kidney. Because it's not receiving the blood it needs to receive, it ups its excretion of renin. Therefore, angiotensin II levels spike. Angiotensin II levels spike. That causes that causes the heart now to start to enlarge. You're getting vasoconstriction. The heart is now pushing against more pressure. In order to do that, the walls of the heart start to enlarge. That's called remodeling. However, with this vasoconstriction, less blood is getting to the kidney. So what does the kidney do? It ups its renin secretion even more. Now you vasoconstrict even more. Now the heart has to get even larger to push against all that, but the kidney still gets less because you vasoconstrict it. So then the heart enlarges even more. Then the heart gets sluggish, the kidney receives even less. Now it makes even more renin, even more angiotensin II. Now essentially, you essentially have this path downward where ejection fraction gets less and less. The heart gets bigger and bigger. The heart now can't feed itself either. You start having angina attacks, and also now your tissues are not being perfused. This essentially is the downward spiral of heart failure. You want to prevent this spiral. You want to arrest it essentially. That's what you want to do. So patients with a left ventricular ejection fraction less than 40%, they have so-called with a reduced ejection fraction, or they have so-called systolic heart failure. Patients with left ventricular ejection fraction of equal to or above 50% have heart failure with preserved ejection fraction. This group, there's no evidence that drug treatment helps this group. So really what we're talking about is this group here. That's the majority of people who have had heart failure. All right, first drug is for chronic heart failure. Chronic heart failure. This is a drug, digoxin. Digoxin. Digoxin inhibits the cardiac sodium potassium ATPase. By inhibiting the sodium potassium ATPase, you create more opportunities for calcium to enter the cell because of the sodium calcium exchanger. More calcium means you have a more forceful contraction of the heart. So this will relieve symptoms. There's no evidence digoxin decreases mortality. It's just good for decreasing symptoms. Digoxin also increases parasympathetic input to the atria. So it's good for atrial arrhythmias. It's not good for ventricular arrhythmias, just atrial arrhythmias. So you get stronger contraction, but you get a lower rate of the heart. Now, digoxin has a long half-life. Digoxin also has a narrow therapeutic window. If digoxin levels get too high, you have problems, big problems. And if you have digoxin toxicity, you're going to use this product here. This is Digifab. There's also a project called Digibind. These are antibodies that you give intravenously, and these will bind digoxin and take it out of commission. Boy, that's cutting my slides off. Ah, there we go. Okay, two last things about digoxin. Digoxin tears up your stomach when you take it. The other thing it causes is xanthopsia. In other words, everything looks yellow. Xanthopsia. Digoxin also messes with potassium. It can cause hyperkalemia. So this is a drug you have to monitor like mad. All right, that's the skinny on digoxin. We'll talk about some pathomimetics next time for acute heart failure, and we'll go from there. Very good.
So did you say that the work of the sodium potassium ATPase that increase